Good afternoon, guests, and welcome to the Weekly with Dr. Tom. This is your way to stay up to date with everything healthcare related across the country. This week, we'll be joined by Dr. Tony Lamas for heart health and diabetes, plus a special feature, the dog days of COVID-19. There will be a Q&A session at the end of the seminar. Submit your questions throughout by using the Q&A button at the bottom of your screen. Dr. Elliott will answer as many as possible live, but all will be answered by case managers in writing. We look forward to your engagement. Now, here's Dr. Tom.
Good afternoon, viewers, and welcome to the 9th edition of the Weekly. Today we move our focus away from diet, exercise, insulin, and special devices to the function of individual body organs and how to best preserve and protect them while living with diabetes. This week, we begin with the heart and are privileged to have renowned cardiologist, Dr. Tony Lamas, as our content expert, joining us from Miami, Florida. Today, we're also celebrating the dog days of COVID-19, acknowledging the special relationship between the canine and human species, especially during these stressful and often lonely times. By no coincidence, Dr. Lamas is also a dog lover. Here are his two hounds, Buddy and Rocky, and I think we'll be seeing more of them before the day is out. But before I formally introduce Dr. Lamas, I would like to do a 2-minute refresher course on the basics of diabetes and the heart. Diabetes carries an increased risk of heart attack and stroke. This risk can be dramatically decreased by attending to the basics. Quitting smoking, number one, if that's something that you're still doing, and then controlling sugar, blood pressure, and cholesterol. We've spoken a lot about sugar on the previous sessions, but if you can get your A1C under 7 and your time in range above 70%, you're on track. With respect to blood pressure, we care most about the top number. If you can get that under 140, I'll be happy. Often this will mean taking a number of different antihypertensive medications. And finally, cholesterol. The one we care about most is bad cholesterol, or LDL. A good value is less than 2.0. Or we like to measure another protein called ApoB, which might even be a better marker of risk. That needs to be below 0.8. Nearly all of you living with diabetes, particularly type 2 diabetes, should be on a statin medication to get to that level of LDL or ApoB. If statin medications don't work, there are other options. For those of you, next slide, for those of you who've already had a heart attack, stroke, or a blockage anywhere, further risk reduction is recommended. Specifically, the addition of several possible medications. The first one is good old-fashioned aspirin or ASA, and if you have an allergy to that, there are alternatives. The next class of drug is a relatively new one, the SGLT2 inhibitors. These drugs dramatically improve prognosis after heart attack or blockage in diabetes, and particularly reduce the incidence of heart failure, which we'll be touching on later. So if you're not on one of those medications, empagliflozin, canagliflozin, or dapagliflozin, please talk to your case manager and me, as we should consider it. And the final drug that has a role post-heart attack or stroke, drugs in the GLP-1 category, specifically semaglutide and dulaglutide. Semaglutide has recently come out as a pill form, so you don't actually have to take a shot, you can take a pill. Now, when all the risk factors for heart disease and diabetes are considered, they still only account for about 60% of the cause of heart disease. There may be something missing, and this is where Dr. Lamas comes in. I know Tony Lamas as chair of the Attac 2 study, which is investigating whether chelation therapy, which reduces blood levels of heavy metals such as lead and cadmium, can improve the health of individuals living with diabetes who've had a previous heart attack. I know about Tony's love of dogs because as chair of the study, he's always motivating us to recruit more patients, and he flashes up his dogs and a cat as well to tell us how they're feeling, because you know that Tony's feeling the same mood as his hounds. Dr. Lamas has had an illustrious career, and it's far from over. He was born in Cuba came to the US at the age of 8, graduated from Harvard Medical School, and is now chief of Columbia University's Cardiology Division at Mount Sinai Medical Center in Miami Beach. He operates in the highest echelons of academia in the United States, having been funded for a number of studies by the prestigious National Institutes of Health. I suspect he and Dr. Anthony Fauci, who we see a lot of in COVID-19 news and the White House, are on a first-name basis. Dr. Lamas made his academic name with cardiac pacemakers, but around 1999 changed courses. Tony, can you tell us in 10 minutes or so what you've been doing for the last 20 years?
Well, it just so happens that I have a few slides that will help me do that. So around 1999, a patient walks into my office asking for a treatment called chelation. And chelation was recognized by cardiologists as a quack treatment, as a treatment that no reputable individual would ever engage in. And I told the patient, absolutely not. That's quackery. Expensive, probably dangerous, and you need to be taking these medicines that I'm giving you. And I don't talk to people that way. And then when I started looking into it, I realized that I couldn't really say that. The data did not exist. The scientific data did not exist to support what I said. But on the other hand, they didn't exist to support using chelation. And I'll explain what chelation is in a moment. And that started really a journey, which is now in its 20 plus year. 2002, we were funded for to the tune of $30 million to do a chelation trial. It ended in 2012. We presented it in 2013. And then we started Attac 2 in 2016. And all along, we've been trying to figure out, well, what is going on? And then we realized at the end of it all, that we were dealing with the elephant in the room. And if I can have the next slide. So when you say that there's an elephant in the room, you mean that there's an obvious problem or difficult situation that people don't want to talk about, but should. Next. And those are toxic metals. Toxic metals, in this case, you see the chemical symbol for lead and cadmium in this room with this lady, and that she represents us. There's near universal contamination with these metals that are toxic to the blood vessels and to the heart. Next. And click one more time. So this is a study that looked at a population that represented the United States. So it's a sample population. And this is a recent study published in 2018 in a prestigious journal, Lancet Public Health, and suggested that about 18% of deaths, or 412,000 deaths annually in the US, can be traced to low levels of lead in the environment. In terms of cardiovascular disease, 256,000 of those deaths traced to low levels of lead. In ischemic heart disease, that's from coronary artery, from the arteries that supply blood to the heart, maybe about a quarter or so might be traceable to lead. Now, this is pretty incredible. And so we're continuing to ignore, I would say that most cardiologists continue to ignore this elephant in the room. Next. Now, mind you, this is not something which is new to cardiology. This was one of the very first papers, scientific papers, that showed premature aging of the arterial system due to lead in 1886. Next. The first paper that showed that, in fact, by using a medicine, a chelating medicine, that is a medicine that is able to extract a toxin from the body called EDTA, you can click again, and this was published in 1956. If you take it orally. If you give it intravenously and you check the urine the next day, what you'll find is that about the amount of lead in the urine is about 3,000% more. And you take anyone, any of us, my age, Tom's age, the older you get, the more of these toxic metals you have. We all have 5 or 6 toxic metals that can be detected in our urine at any time. So go back a little bit, go back to the previous one. So there we go. That's the one that I wanted to show you. If you see that, look at the bottom where it says baseline. These are, I think, 24 patients that we had. These were all, turned out to be all men, everybody over 50. And if you give them placebo, which is really salt water infusion into the veins, nothing happens. Nothing comes out of their urine. On the left-hand side, you see lead. But if you give them EDTA, 3 grams of EDTA, you find almost a 4,000% increase in the amount of lead that comes out. Cadmium is another real bad actor, and that one is a little stickier inside the body, but EDTA can drag it out, 670% increase. And they're really good experiments that show that these are toxic to the arteries. So what happens then if you administer this to patients who've had a heart attack? And this was the 1,708 patients that we had in the first study, in the first trial to assess chelation therapy. So as you can see, at the end of 60 months, the curves diverge. The placebo patients who are receiving all the usual medicines, but they also get infusions of salt water, compared to those who are receiving all the usual medicines, but they get infusions of EDTA, it was actually good to receive EDTA. Now, this was a shock to cardiologists, and it wasn't really a welcome shock. Next. What was even more surprising was what happened with patients with diabetes. This was a subgroup of 633 patients within those 1,708 who also had diabetes. So they'd had a heart attack and they had diabetes. And we found that we could reduce the risk of another coronary event of some kind, either death or bypass or a stent or another heart attack, by about 41%, which is really striking. I mean, just striking. There's really nothing else like this that's been out there. But remember, this is one study and this is a subgroup. Next slide. So what happened? Was I hailed as an inventor, a hero, somebody who had a vision? No. In fact, exactly the opposite happened. My colleagues turned against me. They were dismayed that I had this positive study with something that everybody had studied as quackery, but not really studied at all. It was like a bad rumor that was out there that couldn't be dispelled. Next. And again, we went back, we analyzed everything. We saw that in patients with diabetes, we were able to reduce the risk of death over 5 years by over 40%. Really extraordinary. Like I said, nothing like this. But in science, if you have one experiment, all you have is one experiment. If you have 2 or 3, then you have truth. Next. Click 1. And this shows you the risk of a recurrent heart attack in diabetic patients. 0.48 is essentially, it reduces the risk of a second heart attack by 50%. And it reduces the risk, of having a stent or coronary bypass by about 1/3. Next. So this was interesting, and I went to the FDA in 2014 asking for approval of EDTA infusions to reduce the risk of recurrent heart attacks, improve survival in patients with diabetes and a prior heart attack. And they said, you know what, this is really interesting, but you only have one experiment. And we don't like approving things that only have one experiment. So there has to be a second study. And that's where Attac 2 came in. And I know that some of you in the audience are Attac 2 patients. And I really want to take one moment to say the most humble and sincere thanks. You are truly helping science move forward, and we will get through this study. Right now, we are in the dog days of COVID, and it's really quite annoying and disorienting, but we will get through this. We've been through this for many years. So this is a study of 1,200 post-MI patients, so patients who've had a heart attack and they also have diabetes. Right now, we've enrolled 926 patients. Next. But in the meantime, of course, years are passing. And so I thought that I should also address something else in diabetic patients. And diabetic patients have small vessel disease of the arteries, the little arteries that lead to the feet. And there are 108,000 non-traumatic major amputations in diabetic patients in 2015, many more now. But that's the most recent reliable data I could get. And we know that both cadmium and lead are associated with peripheral artery disease. And so I went to the hospital. I went to my hospital and said, listen, I want to try chelation on patients who have peripheral artery disease. And again, this isn't an original thought. I had asked chelation practitioners, doctors who had started using chelation in their practice, and asked them, look, what about peripheral artery disease? And they said, look, it works. So we started looking at it. Next. So this is an individual who was actually treated in the hospital at Harvard where I trained. And he had, you can see some of these pictures are a little strong. So, you can notice that this gentleman has only 4 toes at this point. He's had 1 amputation. And he already has a little ulcer in that foot. And they've already told him, and the foot is shiny kind of and pink. And it's an unnatural color. And they've already told him that he's likely going to have another amputation. Next. So he gets chelation. And after about 40 infusions, what happens? The ulcer heals. And his feet look normal. Again, an 85-year-old men have feet that look like this. So, if you are young, this is where you're headed. So, and if you're there already, you know that when you look down, that's what you see. So, next. And next, there we go. Yeah, no, go back a little bit. Go back one more. So what's interesting is the bar, you can't see the bottom of the bar, of that big blue bar very well, but that is the percent increase in lead in the urine compared to baseline. So after the first infusion, what was in the urine was 5,700% more lead than at baseline. We really extracted lead from this fellow. Next. So this gentleman actually was scheduled for an amputation. And I had a surgeon in my office who said, yes, I really thought that I was going to have to take off his leg. He had a schedule. He was scheduled for 2 weeks from the time that we started doing these infusions. You can see that by infusion 20, these ulcers are a little bit smaller. By infusion 48, they're gone. Next slide. And again. And next slide. This is extraordinary. This is not a disease that has a spontaneous remission. When you're studying patients who've had a heart attack and they don't have another heart attack, that is, there's no particular way to know that they were destined to have another heart attack. So it is so much less impactful to prevent a heart attack than to take disease and move it back in time. And this is what really is one of the things that really drive me at this point, that we will be able to do this in the future. Next. So, as Dr. Elliott said in the beginning, we believe that the reason is that toxic metals are a modifiable risk factor, and that residual risk that you can't account for by controlling blood pressure, stopping smoking. By the way, cigarette smoke has lead and cadmium in it. Stopping smoking, et cetera, et cetera. All these things that we do, getting your cholesterol down, there's still a risk, and in particular in diabetic patients. And moreover, in many cases, in spite of my colleagues' disbelief, I've been able to find individuals like Dr. Elliott who can see the future and have an open mind and say, okay, let's see if this really works. And again, this is a quote from Victor Hugo: all the forces in the world are not so powerful as an idea whose time has come. And that's where we are. So I'd be happy to take any questions, and we'll follow the agenda. Thank you, Tom.
Wow, Dr. Lamas, that was fantastic. I know I speak for myself when I say that was extremely informative. I think we do have a couple questions now. The first one is going to come from Bruce. Meal planning for diabetes has been emphasizing low carbohydrate intake, which has resulted in me increasing the fats I'm consuming in my diet. What are your thoughts on this? And should I be concerned relating to heart health?
I think that that's a very good question. And we often get into these sorts of situations with diabetic patients who are trying to have a healthy diet, and yet you remove carbohydrates, you tell them they can't have fat, and then all of a sudden they have nothing to eat or nothing appetizing. The truth is that a modest amount of fat will, in a patient who is taking a statin, is really not going to make a huge impact on your LDL or your ApoB. And I think that this is something that you need to take up with your diabetes specialized nutritionist, as well as with your physician, because you'll be able to find a diet plan that suits you. It is never an excuse for having bad diabetes control. We have so many medications to treat diabetes, to treat blood sugar, to treat lipids. And remember, the elephant in the room for diabetes, of course, is weight. We really have to it's very important to try to be thin. I always ask my patients to bring me a picture when they were 18 or 20 years old. And I tell them that that's what their body grew up thinking that they were going to have to deal with for the next 50 years. And it's not made, think of your car. You have this engine, and then all of a sudden you have it dragging a gigantic 18-wheeler semi. Well, sorry, it's not going to work well.
Fantastic. One more question from Donald here. Dr. Lamas, I had bypass surgery 3 years ago, and there were 4 blockages that required bypass. The physician could not reach one, therefore only 3 were completed successfully. What happens to the heart muscles and the valves in this case?
Well, coronary bypass surgery is actually a very good operation. It tends to, for the most part, you get excellent revascularization or restoration of blood flow to areas that otherwise don't have blood flow. And the risk of dying during a routine coronary surgery is in the 1% or less. So for a big operation, it actually is very successful. Not all obstructions, especially in patients with diabetes, can be bypassed, but not all obstructions are are equally important. In many cases, what occurs is that in diabetic patients will have little twigs, little arterial twigs that can't be bypassed. You can't plug another bypass graft onto them. And that can be a source of problems, but almost always, if they're small enough, if you mind your P's and Q's and keep your cholesterol and blood sugar under control, stay active, lose weight, have an occasional stress test, and report to your doctor when you have symptoms that suggest heart disease, you're going to be okay.
Fantastic. Thank you, Dr. Lamas. At this point, we're going to go over to Dr. Samuel very quickly for a brief hand washing demo and a couple poll questions. Dr. Samuel, please.
Thank you, Tristan. Remember, if your hands are clean, you're less likely to get COVID-19. I'm going to demonstrate to you the WHO or World Health Organization's technique of hand washing. First, rinse both hands completely with water. Apply enough soap to cover all hand surfaces. Then, rub your hands together, palm to palm. Right palm over left hand dorsum with fingers interlaced. Left palm over right hand dorsum with fingers interlaced. Palm to palm with fingers interlaced. Tips and backs of fingers on opposing palm. Both hands. Rotational rubbing of left thumb in right palm. Rotational rubbing of right thumb in left palm. Rotational rubbing forwards and backwards of opposing palm. Both hands. Now, rinse both hands with water to wash off the soap. Now, use a single-use dry towel to dry both your hands. Use the same towel to close the faucet. Now, your hands are clean and safe. Back to you, Tristan.
Thanks, Dr. Samuel. At this point, we're going to go to a prevention slide and hear from Dr. Elliott.
Thank you, Tristan. So in addition to washing your hands and of course not touching your face, it's COVID-19 on your hands when you touch your face that is the primary source of infection, we believe. We also want you to clean surfaces that have been touched by people, the cleanliness of their hands unknown to you. We want to remind you about the importance of social distancing, keeping 2 meters apart. And then whenever you go outside your home, we want you to wear a mask. Prevention is the best cure. Back to you, Tristan.
Thank you. We're going to get one more question in here. It's from Gordon to Dr. Lamas. 2 questions. As a journalist, I wrote about chelation more than 20 years ago. And as you said, it was considered quackery by the medical establishment. Is it better accepted / being used / do medical plans cover it anywhere? And 2, are there any bad side effects to the drug that draws out cadmium and lead?
Those are excellent questions. The first one is, have my colleagues accepted this as a treatment? So in the 2014 guidelines for the treatment of stable ischemic heart disease or stable heart coronary artery disease, chelation was moved from class 3, which means if you do it, you are really a criminal quack, to 2B, which means you can do it in exceptional circumstances. Now, there is a lot of stuff that we do on it, that I do on a daily basis in taking care of heart patients that are in that 2B category. So that was a huge victory. That's on the good side. On the bad side is, and still on the good side is, that rather than being thought of as, Tony Lamas, who somehow something happened to him, he went crazy and studied chelation, people now accept that there is a legitimate scientific inquiry. Let's ask a different question. Are there any cardiologists practicing chelation in the community? The answer is really no, not really. There are a few with Attac, and that's it. Do health insurance plans cover it? Medicare has a specific ruling that they do not, will not, and never allowed to cover EDTA for vascular disease. And that was pushed through by the medical associations in the 80s or 90s, or early 90s. There are some commercial plans that we can get it through, but it requires a fair amount of maneuvering on my part. So the answer is that cardiologists recognize that there is legitimate inquiry going on, but they are not ready to practice it. And in their heart of hearts, they think this is nonsense.
Thanks, Dr. Lamas. Are we going to?
I have a comment, Tony, that I presented grand rounds to the Division of Cardiology on Attac 2, and I've got an open mind, and I'm sure you have an open mind. If TAC 2 comes back totally negative, I suspect you're going to quit. I'll let you answer. I'll let you comment on that. But if it comes back strongly positive, as we expect it to, based on the original study, sub-study of people with diabetes, the question is that enough? Will that change the practice of cardiologists? And the audience responded quite strongly that no, 2 is not enough. There will need to be a 3rd study. So, for the viewers, many of you have done the TAC 2 study. I think it's 35 or so of you. And many of you have done a lot of other randomized control studies where we don't know the outcome. And most of them do show a positive, outcome, meaning that the science around the study was good and the question was asked well. So I want to thank you for your support for research at BC Diabetes. It's a big part of what we do. And I'm especially grateful. Tony, what about a 2nd or 3rd study?
Well, TAC 3, I'm doing actually TAC 3A already, which is in patients with critical limb ischemia. So those are patients who, those pictures I showed you was a pilot study without a control group. So TAC 3A is a small study. It'll really be a pilot, hopefully, for a larger trial. So 50 patients. All of them with critical limb ischemia, so they have either rest pain or open lesions. And there are 30 will be assigned to chelation, 20 are assigned to placebo infusions. We're keeping close eye on that to make sure that if it tilts in favor of treating the patients, then that we really need to stop and then treat all the patients, because this is there are no games here. TAC 4, I think, has to be cognitive improvement or cognitive change, because I've observed it. Of course, by the time that TAC 4 is being done or even planned, I will look like Gandalf. I don't know if you remember in The Hobbit. He was the guy in the white robe with a long white beard. So, I don't foresee retirement anytime in the near future.
Fantastic. You look young to us, Dr. Lamas.
It's the makeup.
Now, for Dog Days of COVID, our first contestant is Dave Berg with his beloved dog. Our furry friends keep us company when times are difficult. And back to the Q&A. This one's for Dr. Tom from Bernard. Dr. Tom, when you go for a blood test, do they automatically check your lead levels?
Bernard, I can give you a categorical answer. That is no. The only time that blood lead levels are measured outside of, well, they're only measured under research circumstances. So, Tony, we're measuring blood lead levels in TAC 2 for sure, aren't we?
Yes, we're measuring blood lead, and we are also measuring about 20 metals in the urine. These are being actually measured at the CDC, which now, of course, got involved in politics. So I'm hoping that, this has no involvement in it. But but the truth is that whether the level of lead that we have really matters is, I think it's an open question. We all have lead, and none of us should. So the amount of lead that the average human has now is 1,000 times more than the amount of lead that existed in pre-industrial humans, based on studies of skeletons. So what we have is so high, even though it's low compared to the way that it was, say, in the 70s, it is still so high. The body has no way to handle this stuff. No way to handle it. No clear way to excrete large amounts of it. Lead is a heavy metal. It was deep in the Earth's crust until we started dragging it out and putting it in gasoline in particular and in paint. So if you measure it, if you're in your 70s, you'll find a blood lead level of 1 or 2 micrograms per mil. And the United States Environmental Protection Agency says that that's okay. Well, I would say that that's 1,000 times higher than what you're supposed to have. So how much poison is enough poison? Is too much poison? Is an okay amount of poison?
A fascinating subject. At this point, we're going to kick it over to Dr. Tom to speak about Arise HF. Dr. Tom.
Dr. Lamas has referred to abnormalities in the heart of people with diabetes, and it's not completely understood why it occurs, other than that it's caused somehow by diabetes. BC Diabetes is just about to start a study that's looking at a potential treatment for heart disease in people with diabetes who don't have blockages. And the study's called Arise HF. People eligible for the study have type 2 diabetes, they're over the age of 40, and they've never had a heart attack or a blockage before, and they've never had heart failure before. If any of you are interested in this, we would be happy to screen you. Part of the screening is an echocardiogram, which is a beautiful picture of the heart, as well as blood tests. So we will be approaching patients in the next months for the Arise HF study.
Thanks, Dr. Tom. Luke, can we go to a couple more dogs? Our next contestant is Patricia Reynolds and her beloved dog, Astro. As you can see, they're both very happy. Yet again, Trish and Astro both sitting together on a bench, enjoying beautiful Vancouver. Now back to the questions. The next one is from John. Should we be testing for lead and cadmium when we have our blood panels done? Dr. Elliott.
Well, let me say this: if TAC2 repeats the finding of a 43% reduction in death, then most certainly chelation therapy will become talked about a lot more and hopefully practiced at BC Diabetes. Whether we need to have our levels measured, I think Dr. Lamas has already alluded to this, that the lead levels may actually be irrelevant. Just because you find a lead level that's not high doesn't mean it's good, because it's 1,000 times higher than it was compared to 200 years ago. So Tony, anything to add to that?
No, I think that one of the important pieces that we forget are sort of what are environmental sources of exposure to these things. Lead is tough, but it has a lot to do with your water supply at this point. Whether you live in a house that used to have lead paint, and when they do the lead abatement, all that stuff gets in the soil. The cadmium is actually quite interesting in the sense that you can get a lot of cadmium from cigarette smoke, And cadmium also can be in green leafy vegetables. Cadmium is taken up avidly by green leafy vegetables like tobacco leaves, for example, but also depending on what's in the soil and what's in the fertilizer, by spinach, for example. So, you know, the idea of trying to eat organic and knowing the source of your vegetables is actually quite important for this. But yes, I think that ultimately we may end up finding that there is a level of cadmium or of lead that is associated with excess cardiovascular disease. We're just not there yet. So I wouldn't embark on testing this right now.
And Justin, if I could just comment further, that you know, we're talking about lead. It's not a proven risk factor for heart disease. We are trying to prove it, and we expect it to be positive. In the meantime, you know, please attend to your sugar, to your blood pressure. Make sure you take your statin medication. Quit smoking and lose weight if you can. Those things are the focus that I want you never to take your eye off. So, you know, I want you to stay with that message way beyond today.
Our next contestant is a fellow named Dave Manhas and his little guy named Milo. They look like best friends. Up next is our beloved Marla, who's the research manager at BC Diabetes, and her little guy named Chip, 2 peas in a pod. Back to questions here. One from John. Dr. Lamas, does what you're talking about relate to people who haven't had a heart attack? What are your thoughts on this?
I think that this question really extends the TACT studies in a very logical direction. The reason that we just chose patients for our studies who already had vascular disease, who'd had a heart attack specifically, is that when you design a study, you design it to prevent recurrent events, more bad stuff. And you're more likely to have something bad happen if you've already had something bad happen. So it keeps the group of patients you're studying small enough so that you can actually afford the study. This is where economics gets into it. If we did a study of healthy people, you would need to study 20, 30, 40, 50,000 of them. The budget would be impossible. So you couldn't do that study. What's in my heart of hearts tells me that yes, absolutely. How much poison is a good amount of poison? Well, 0 poison. So individuals with risk factors, and probably you might even extend that to say, well, most people really should be thinking about how are they going to do lead abatement and cadmium abatement of their own bodies.
Thank you. Back to dog days of COVID. Up next, we have Bill and Timber. Bill is the COO at BC Diabetes, and Timber is a therapy/office dog. We'll go to another question now from Norma. Dr. Elliott, when am I going to find out if I'm on TAC2 chelation or placebo?
Well, I know the answer, Norma. It's when the study is complete, and I'm going to let Tony take over from here. Tony, if the NIH allows the study to restart, when do you think we will have completed the 1,200 people? When will we know the results of TAC2, and when will Norma know whether she got the real thing or not?
So I think that the timeline has really been altered by this whole COVID thing. And likely we will end up recruiting about 1,000 patients maximum. That will still give us enough events and statistical power to discern a difference between groups. We will probably complete the study in either at the end of 22 or in early to mid 23. And once the database is locked and the data are analyzed, then each site will receive a list of what their patients were on. And it'll be up to the sites, because I'm not allowed to communicate with the patients. It'll be up to the sites to let their patients know what they were on, both with the diabetes as well as with the high dose vitamins, those 6 pills that are so devilishly hard to swallow every day. So it's, I think that that's why I really think that you guys are the extraordinary heroes of cardiovascular medicine and cardiovascular science. These science could not progress. We could not progress. We couldn't move forward if we didn't have patients who are selfless and who participate in these studies.
Our last couple of the dog days of COVID, we have Wendy Chidley and Noodle. What a happy life it is. And last, we have yours truly, Tristan, Teddy, and Laura. We are grateful for our little friends. We have a couple questions remaining in our time. From Connie. Dr. Elliott, can you speak to the side effects of chelation?
Well, I can tell you, Connie, that in the original Attac study of 1,700 patients, the side effects were the same whether you got chelation or whether you got the placebo or salty water. So that's very reassuring. It means that whatever, it suggests to the scientists that whatever complaints the patient had nothing to do with chelation. And Tony, perhaps you can enlarge upon that.
Tom, there's very little more that I can say. We gave 55,222 infusions, about half of which were active, half were placebo. The number of serious adverse events after the infusions were about the same in both groups, statistically identical, numerically more in the placebo group, as luck would have it, which is really funny. The key, though, is that with any medicine, you have to be careful. The infusions of disodium EDTA have to go in over about a 3-hour period. Sometimes a little more. Every once in a while, you make a mistake and make it a little less. But it's got to be around that 3-hour period. The disasters that have occurred are when those are just pushed in, and particularly in children. So as long as simple rules are followed, this drug is safe.
Thanks, Dr. Lamas. We have one last question. It's from Greg, and we're going to go to Dr. Elliott. Is there a correlation between testosterone and diabetes, or testosterone and reducing metals in our body?
Well, Greg, that's a good question. Right from left field. I'm not aware of any hard data on that. I can tell you that in men, the more overweight a man is, the lower his testosterone tends to be. And the more overweight a woman is, the higher her testosterone is. Now, men have 10 times as much testosterone to start than women. So, I can tell you there's that correlation related to weight, but not specifically to diabetes. Was there a second part to that question that I lost?
No, I think that's pretty good. We're going to go to you for your outro now, Dr. Elliott. Please.
Well, it's been a striking session. Dr. Lamas, thank you so much for sharing with us, for talking about the elephant in the room. It's critical for us to execute the TAC2 study and get it finished so that we have an answer for you. But it begs the question of for our social scientists and for public health to not to look at mitigation of these levels. It reminds me of how beholden we are to you, BC Diabetes clients, for doing our clinical trials, our randomized clinical trials, for giving of your time, even though you know that there's often a 50% or a 30% chance of getting a placebo. So we're particularly grateful. Without it, we would have no advancement in science. It's wonderful to have seen everybody's dog pictures, and what a reminder of how soothing these creatures are to our mental state. Next week, we will discuss diabetes and eye health, and our special guest will be Dr. David Albiani, a diabetes retinal specialist here in Vancouver. Now, for many of you, we know that your questions were not answered live. We will do our best to answer these in the next few hours and days via email. So thank you very much, everybody, for attending the weekly.
Okay, now at this point, we'd like to say a special thank you to our partners, Dr. Lamas, who was absolutely fantastic today, and our beloved audience, you. Have a lovely afternoon, a lovely day tomorrow, and enjoy the weekend. See you next week.